A 25-year-old man comes to the physician for recent headaches. He has not seen a physician in many years. His pulse is 80 per minute, blood pressure is 180 over 110 millimeters mercury, and his BMI is 24.5. He has no major hospitalizations. He says he has no family history of hypertension and that he is sedentary, but eats a healthy diet. Laboratory tests show elevated plasma renin and hypokalemia. Which of the following is the most likely explanation for this patient's symptoms? Choice A, plaque formation and chronic endothelial damage. Choice B, abnormal cell development in endothelium. Choice C, segmental necrotizing inflammation of arteries. Choice D, abnormal release of catecholamines. Choice E, incomplete separation of inferior pole of metanephric ducts. I'll wait 5 seconds and answer the question. All right, so we have a hypertension patient here with hypokalemia, which immediately starts making you think of the ROS system. And because we have elevated plasma renin, then you know that this is probably a secondary hyperaldosteronism. Because if it was primary, like a aldosterone secreting tumor, it would cause negative feedback on renin, and renin would be low. Now, in this case, we have a patient that mostly doesn't seem to have any major risk factors. You know, he's not obese. He doesn't have any family history. Only thing you really have to go off of is that he's pretty young. So when you see something like this and you have the elevated renin, you want to be thinking fibromuscular dysplasia. Now, classically, of course, you'd be thinking young female patient, but this is a male patient, but of course, it's also possible there. As far as diagnosis go, it's really just playing the odds in a sense. And you also want to know the basic cause of fibromuscular dysplasia, which is choice B, abnormal cell development in endothelium. Basically, in fibromuscular dysplasia, you have abnormal development in the tunica media, and your normally elastic tissue gets replaced with collagenous and fibrotic tissue, which is why it's called fibromuscular dysplasia. And this can also happen sort of segmentally almost, which is why you can get a string of beads sign on imaging. And of course, in this question, another way we can do this is to just eliminate to get there. So let's just look at the other answer choices because you should be able to recognize them and eliminate them. Choice A, plaque formation and chronic endothelial damage. This is just talking about generic atherosclerosis, right? Now, this can, of course, cause renal artery stenosis, which can cause very similar presentation. But usually, if I was going to give that to you, I would give you a bunch of other risk factors. This patient would be smoking, have diabetes, or they'd be a lot older, most likely. In a young patient that doesn't otherwise have some kind of previous history or family history, fibromuscular dysplasia is far more likely than atherosclerosis. Choice C, segmental necrotizing inflammation of arteries. So this is obviously referring to some kind of vasculitis, in this case, polyarteritis nodosa. Now, polyarteritis nodosa can also present with something that kind of looks like the string of beads sign, but you would also have more systemic symptoms. Patient would probably have fever, weight loss maybe. You might have hepatitis B or C infection. You'll have all kinds of systemic signs. Like I said, you might get ulcers across the body. You might get mononeuritis multiplex, which is where one long nerve has a neuropathy. And polyarteritis nodosa also tends to present a lot later in life than fibromuscular dysplasia. Something like age 50 or so is about the average, I think. So fibromuscular dysplasia is just a better answer choice here. Choice D, abnormal release of catecholamines. This is referring to a pheochromocytoma. You, of course, want to be thinking about stuff like multiple endocrine neoplasia type 2 or von Hippel-Lindau, any number of cancer syndromes that can cause pheochromocytoma. Headache is a common presenting symptom for pheochromocytoma like this patient, but obviously the thing that lets you eliminate it immediately is that you have elevated renin and hypokalemia. Those things don't really happen with a pheochromocytoma, which secretes catecholamines. Choice E, incomplete separation of inferior pole of metanephric ducts. This is a distractor. This is referring to a horseshoe kidney. Horseshoe kidney can increase the risk of kidney stones and maybe hydronephrosis, but it's not really associated with hypertension or hyperaldosteronism. So bring it back when you get a young patient like this with hypertension and seemingly secondary hyperaldosteronism, and it doesn't seem like they have any other systemic signs or signs that you might be suspecting some other condition, you want to be thinking fibromuscular dysplasia first. And of course, an obvious giveaway would be something like they tell you that there's a abdominal bruit or something. Hope you found this video helpful. I'll see you in the next one.